Folks, if you are on YouTube watching us, you're behind the scenes with our esteemed panel. This is Eric Glazer, Bright Spots in Healthcare. We're getting ready to go live via Zoom to our live audience. Bear with us for just a moment. Folks, if you are, there you go. All right, I think it'll be go time. Sherry, this will record automatically. And you've got the two polls ready, I'm assuming, Sherry. If there's any problems, you're going to chirp in now. I don't hear Sherry chirping in. Sherry, you're with us.
Yeah, no, I'm all set.
Okay, great. All right, folks, have fun out there. Let's do this. Hello, everyone. Greetings. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each week, we bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, at health providers, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on our show are able to be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. I know there are a lot of first-timers on the live broadcast today. If you have not subscribed yet to the Bright Spots in Healthcare podcast, I encourage you to do so. We've got a lot of incredibly informative interviews with leaders at health plans and provider organizations that you all know and maybe you're part of or compete against that share a lot of great ideas, especially over the past 8 months. So I encourage you to, wherever you consume podcasts, Spotify, Apple, Google Play, Stitcher, wherever, Amazon, find Bright Spots in Healthcare, click on subscribe, and then once this live recording is over, within about 24 hours, this episode will drop in the podcast feed. And whenever you're unable to make a live event, you will get that content to your phone or tablet or wherever you listen to your podcast. So I encourage you to do that as well. I'm going to put up a quick poll. This is unusual. We don't do this all the time, but we're big into 2022 planning right now. We're doing a little bit of 2021 Q4 stuff, but mostly 2022. And we would love if any of you who are regulars or even newbies who want to meet with our team to talk about some of the programming ideas we have, our entire programming schedule and what we're planning on doing throughout the year. We know the hour that you're spending with us is incredibly valuable time. We want to make sure each and every episode is valuable. So we're going to be setting up some meetings with our team to go over programming, also to discuss with companies who want to support our programming and be part of it and do sponsorship. But if you want to get on a call with our team to talk about 2022 and maybe some Q4 programming and content ideas, maybe you have some guest ideas, we'd love to set up a meeting with you. I'm going to put up a poll. If you'd like us to reach out and set up a call with you on Zoom, we will do that. Just click on yes. If you're not interested or you're already too busy, fine, just leave it blank or click on no. We will not bother you unless you click on yes. So thanks in advance for doing that. Today's episode is compliments of our friends at Icario. If you've never heard of them, well, they are a not so new anymore, formed merger between Revel Health and Navu Health. They are a health action platform that unites pioneering technology, data science, and behavioral insights to connect everyone to better health. You could check them out at icariohealth.com. I'm going to spell that for you. ICARIO health.com. And I'll tell you a little bit more about them later on the show. But I do view them, and these are my words, not theirs, as one of the true unicorns in healthcare because they combine innovation with pragmatic non-healthcare thinking into driving better outcomes for all the people you take care of or you insure. And I'll tell you more about what I mean by pragmatic non-healthcare thinking later on in the show. We do bypass full bios and introductions in the interest of time. We're going to be really tight on time today. So if you've not reviewed the bios of our esteemed panelists. Our producer, Sherry Keel, has just posted a link. You'll click on the link. You'll see the 4 photos of our panelists. Just click on each one of them. You could see the incredible experience and skill set that they have and get a little bit of a preview of some of the great information you're about to receive. So check them out. All right, today's episode, we're going to cover CADE, we're going to cover care, we're going to cover social determinants of health, data and analytics, but also how to creatively use face-to-face interactions to drive trust, relationships, engagements, and overall better economics in healthcare. I want to start off with some current events. The Pfizer vaccine, as you all know, has been given full approval by the FDA. However, we also know that many Americans have yet to take the vaccine. So if I could summarize, in my opinion, one of the major forces behind that is of this low vaccination rate, relatively low vaccination rate, is trust, especially in underserved and minority populations. So I am going to bring on a couple of our panelists to talk about how they are approaching building trust, successful programs that you've put into place, leveraging social determinants to address this trust issue, to drive more healthy vaccination rates. To begin the festivities, let's bring on RJ Briscione. He is the Senior Director of Social Determinants of Health Strategy and Execution at a little-known company called CVS Health Aetna. So RJ, why don't you start us off?
Hey, Eric, thanks so much. First of all, thanks for having me. Thanks for thinking of CVS and Aetna for this. Really glad to be here. So yeah, CVS, we really feel, and I think we're correct in this, and that we have an important role to play in not only delivering the vaccines, but delivering them equitably and really doing everything we can to get those vaccines into the communities that are most needed, where they're most underrepresented, and then also to really work on the ground with local organizations to try to combat some of that hesitancy. So really kind of a 3-prong approach that we did this. And I want everybody to kind of go back in their mind to a time when vaccines weren't readily available, right? So when the vaccines were, when they were first at the beginning of this year, say from like January to about May, as the availability ramped up, we really took a very, I'll say, scientific approach to how we were going to get these to the underrepresented communities first, which I think is important. So kind of a 3-prong approach to doing that really honestly, and I'm here to talk about it. I played a small role in it, but amazing, incredible team from across the enterprise. When I say enterprise, that means CVS Health plus Aetna, and I'll talk about how that came together in a little bit. Community clinics. So those are clinics, and we had some great experience with this for testing first, back when it was just testing before vaccines were available. Clinics in the community where people are used to going to. So this is their neighborhood churches, this is their neighborhood, sometimes FQHCs or free clinics where people are accustomed to being. Second one was pop-ups. Pop-ups came in a little bit later on, but pop-ups are super interesting in that where there was potential for a good number of folks to come in and get vaccinated by a sponsoring organization. So some examples of that here in Atlanta, where I am, MARTA, which is our Rapid Transit Authority, and their employees, they're very concerned for their employees. So they had pop-up clinics at not only where the employees come in and the transit stations, which would also work for kind of anybody coming by. There was on-site registration for that. The Latin American Association, and then DeKalb County, which is a large county in Metro Atlanta's government, right? So pop-ups were hosted and set up and being able to do fairly large numbers over a short amount of times, really working with those communities, having people on site there to talk through some of the hesitancy. The bigger two that we spent the majority of the time on were those community clinics that I mentioned, and then in the stores with outreach, which I think is important. So the first thing we did was, when we could really only get it to the stores very early on, we got really deep into the data, and the store selection went to the communities that were where we had the highest share of underrepresented minorities representing the area around those stores, right? And then, but just putting it in a CVS, we know is not good enough, and we know CVS and Aetna are possibly not the most trusted voice when it comes to who you want to get your vaccine from, right? So as we had the availability in the stores, we did two things that I think were really, really unique and really significant. And that is we held a number of reservations available for those underrepresented communities with low. We've seen, I think, in the pandemic, this idea and thought of web or high-speed digital access as a new, it's not a new, but as a highly visible social determinant of health, right? So what we did was partnered with community organizations, some of the churches, a lot of this is where the Aetna piece came in. There's really great Aetna teams around the country that their job is to be on the ground and connected to the communities they serve, especially for Medicaid, Medicare, right? So we have these excellent relationships with these organizations. So we gave them the numbers and the opportunity for how to register for the vaccine appointments ahead of time before we just opened it up, so that when you saw, I remember seeing news reports of people with 6-7 devices like I have on my desk here, like I could be an Apple store right here, right? All ready to go like the minute they launched, and people figured out real easy when we were loading new availability in, right? So I think that was super important to have that in the stores, and then have the outreaches, and then also be partnering with any organization really that wanted to for those community clinics. So working with organizations like YMCAs here, and a great, just real quick story to directly answer the question on hesitancy. The Atlanta mission here in Atlanta is essentially it's a shelter, but it's also obviously has a lot of services available to it for people experiencing homelessness to get back on their feet. And what we did was we brought CVS pharmacists who represented that community, African American or Latin pharmacists, to just go in and explain talk through the hesitancy right there in person with the folks in the Atlanta mission. And we saw a really nice conversion rate on that, right? And then just real quick results, the way we measured this, I really loved, I wish I could take credit for this, people smarter than me. The way we wanted to measure this was, did we get vaccines to a higher percentage of underrepresented minorities versus the local benchmark? So what is the local area percentage of Black or Latin? And did we do better than that? And we did in all of these. And so we ended up running 14 community clinics, 11 different pop-up clinics around the country, and then the thousands of CVS stores with those outreach opportunities that I mentioned, which was an additional 20,000 vaccines. So those are 20,000 vaccines that really we think probably wouldn't have gotten to folks based on what we think about where these folks were as far as hesitancy goes. So
is that something you guys are going to continue to extend, or where are we at today now?
Yeah, that most of that work, I shouldn't say it's wrapped up, but it's available, right? Like we still have all of those partnerships with those organizations. We have the messaging for them. We are doing, there's very specific outreach. In fact, as I was preparing for this, on CVS YouTube channel, there's fantastic walk through a YouTube a playlist of walkthrough with both an African American and a Hispanic, one of our pharmacists, CVS pharmacists, to walk through all of the questions, kind of an FAQ that runs in a playlist that's really available for anybody to go to. But we have those things available for those organizations that we're working with and always will be. Yeah.
I know I said to everyone we have a packed schedule, but I will try to integrate some of your questions into the conversation. Some of the questions you guys submitted upon registration are already planned to be incorporated, but if you have questions that came up and spawned, let's say from RJ's success story that he just put in front of you, you could use the Q&A module. By now, everyone's Zoom friendly. 2 years ago. I had to explain what the Q&A module was, but please use the Q&A module for your questions though. The chat window could get really busy, and Sherry and I, who manage all this, we're going to get you your questions if we use the Q&A module. So thanks in advance for doing that. I want to stay on this topic of sort of staying local and figuring out how to build trust. And so I want to bring in another one of our panelists to talk about an interesting story down in Arkansas. So we have with us Dr. Creshelle Nash. She is the medical director for health equity and public programs. Like 10 years ago.
Got it.
10 years ago, I do not think there was a title like that. Really excited to see that title in place at Arkansas Blue Cross Blue Shield. So welcome, Creshelle. And what are you guys doing around the vaccine that's unique and impactful?
So first, let me say thank you for allowing me to be here, and thank you for the invitation. And RJ, thank you for your story. I think it will resonate with the audience and some things that I'm going to talk about.
Right.
One of the successful programs that we've had to address social determinants of health has really informed our efforts around the vaccine and our outreach. So I want to very briefly tell you about that. And then dovetail and show you how it fits with the vaccine rollout. It is a program, a partnership with a community paramedicine program. That's community paramedics who go out and make visits. We looked at our data, and we could identify in our Medicaid population, or our exchange population, high-risk people, i.e. people who have increased ED utilization, increased hospitalizations, no PCP, chronic disease, all of that stuff. But we couldn't engage them. So we referred them to this program, and our community paramedics would do outreach and engagement and do a home visit and a home assessment with the population. And really what it did was open the door for the health plan, both literally and figuratively. When we made that contact, then we could assess and get those members' social needs met with our team of case managers and social workers. And ultimately, what we found was that this program was really effective in lower income communities and in African American communities specifically. So that's an example of, a health equity program. So what did we learn from all of this? In addition, it's that what they brought was trust, that word that you keep bringing. People who have trust, who are on the ground, who have been in communities or are in communities working on these issues and addressing social determinants of health and bringing resources to bear directly. So how does that fit with the vaccine? Well, we have been, as you know, in Arkansas, we are in a very hard place right now with the Delta variant, but we are working hard on those partnerships with faith-based communities, with civic leaders, with minority healthcare providers, boots on the ground, community by community, to address those issues and social determinants of health. And this partnership and this trust, as you know, is built over time, and it's going to roll post-COVID, because there are many existential crises in underserved communities at this point.
Awesome. That was great. I keep the questions coming in, folks. I see a bunch of them now are moving over to the Q&A module. I'm going to throw one question out. I'm going to start with you, RJ, and Creshelle, if you want to jump on top of it, you can. Are you surveying those who will not get the vaccine to find out why their continued hesitancy, and how can you address those individuals? So RJ, I'm going to start with you, and Creshelle, if you want to jump on top, you can.
Yeah, I actually don't have that. I don't have great insight on that. I don't think we're running active surveys on why not right now, except for potentially, you may have seen in the news yesterday. So we do have a mandate as of yesterday for most of our employees, with some exceptions, as of yesterday, with the announcement of the FDA approval of Pfizer. So there is obviously active discussion within our own employees, but I don't believe we're running surveys on kind of general population on them.
I think I've been involved with multiple communities who have done multiple surveys trying to figure out this question specifically. There are people who are kind of wait and see. We're getting those wait and see people off the fence now, especially with the FDA approval of Pfizer. We have a component of people who are mistrustful of the healthcare system, and for some good reason, historically and contemporarily. We have people who are COVID skeptics still in different communities, and we're still dealing with accurate information to combat myths that continue to circulate. So we're trying to address all of those different constituencies by some of the things we've already talked about. The messenger matters, right? So minority healthcare providers in minority communities speaking truth and answering questions around health equity, health disparities, and the larger, and we're making some progress.
Okay, great. And we probably could do an entire session just on this specific niche topic. And to that end, folks, I've been getting a couple of private messages. I'd put a poll up at the very beginning of the show. So those of you who arrived late, you probably don't know what I'm talking about. But as we're planning the Q4 and 2022 programming, if you want to meet with members of my team or yours truly to talk about programming that we should be putting on, we're really careful to really work with all of you to do that. I'm going to have Sherry put up the poll one more time. If you want to meet with us one-on-one for 30 minutes just to advise us on what programming you'd like to hear, we'd like to hear from you and meet with you directly. I'm going to switch gears a little bit because trust is not just pandemic specific, and it's not just for the underserved populations per se, but it's also for all different market segments, including our seniors and our Medicare population. And it's not just about getting them to trust a medicine or a vaccine, but it's also about getting them to trust communications to adhere to treatment or to engage in treatment. So I want to shift to seniors and communication and talking about how the words we choose in our communication and the vehicle we choose to deliver those words and how critical they are into driving engagement and behavioral change. And I know we do such a subpar doing that in healthcare. So I'm going to bring in Lora Alexander to talk about how we can do better. Lora is the Vice President of Engagement and Design at Icario. And so, Lora, could you explain or give us an example of some things that we are trying to do better or that you're doing better with your clients to drive better engagement around our Medicare population?
Yeah, absolutely. And thank you guys. This is such an exciting opportunity to even have this kind of communication where we can all learn from each other and hopefully continue to do better. I'm thinking of something that's tangentially attached, but not exactly the same as COVID, because I don't want us to stay on the same topic, which is flu shots, right? Or flu vaccines, which kind of come alongside. And I wish it was as straightforward to do with COVID, but of course it isn't. So what our organization does is we engage members around healthcare decisions, right? And to help try to tip the needle a little bit to engage people in healthcare activities that we know that are beneficial and useful and necessary. So when it comes to our senior populations, we have always paid attention to the best and most effective ways to communicate with them. This includes the channel, the frequency, the messaging itself, and it kind of draws into question or to thought the equity versus equality issue, which is, do you just converse with everybody exactly the same and say, please go get your flu shot, and everybody reacts similarly or they don't? Or do you try to tailor the messaging to the needs of the actual participants? And so that's what we're doing. And so we do, my team says that this is my favorite thing to say in the world, which is probably true. We do a lot of research to try to figure out what is the desires, the needs, the reasonings behind people's behaviors so that we can help shift that needle. One very high perception in the Medicare population is that they don't like to use technology for healthcare, that they don't use email, that they don't use text, that they don't use. So of course, instead of just taking that at face value and looking at the equity versus equality issue, we went out and started having conversations to talk to what ended up being hundreds of seniors, hundreds, and different zip codes and in areas that were within. My favorite story is in California, we went to Long Beach and Riverside and LA County and the OC, all within 10, 15 miles of each other. And it was 4 different planets. They did not only did they not want the same channels, they didn't want the same communications, their incentives were different. But one thing that we noticed, and it was super important, is that within the communication journey for our Medicare populations, most of our seniors did want to use technology for some things very distinctly. So if you're thinking about the flu shot, we'd say, do you want to get information about why flu shots are important and that sort of thing in your email? And they're like, no, that you send in mail, because I need to spend time with it. I need to read it. I need to stick it on my refrigerator, which is still a thing. And I love that. I need to have my granddaughter read it to me. But when it came to things like, do you want a reminder of the fact that every year you should get a flu shot? They said, oh, email's fine for that. And if they talked about the actual appointment, like a reminder that you've got this appointment coming up, if they used text, which is, our populations, our Medicare populations are certainly, especially the younger ones, using text, that's where they preferred to get that. And if they didn't want it that way, they wanted it by phone. So what we've come to realize is that the messaging, of course, as we've talked about, is so vitally important. And we know that, and the journey itself, but even the mode of communication can vary based on how and what we're talking to them about. And the more choice we gave them and the more opportunities we gave them to kind of shape their own experience, the higher engagement we got. And we have this across the board. I mean, I'd like to just say it was in flu shots, but everything from breast cancer screenings to COVID, which we're not going to talk about in this part, to you name it, annual physicals, using different methodologies to engage different populations had a much bigger impact on certain groups.
Fascinating. We have to be so much better at that in healthcare. I think another important part of this is journey mapping. And I know a lot of folks are doing it, but maybe with some success more than others. So I want to bring in Tejaswita Karve, the Director of Quality Improvement at Johns Hopkins Healthcare. And Tejaswita, I'd love to talk again, stay on the same line of like, how are we shifting this kind of mode of communication and engaging Medicare members more effectively? And how are you doing it at Johns Hopkins?
Thank you, Eric. And I want to acknowledge. Start with an acknowledgement for not only inviting me and all these wonderful colleagues of mine who have experiences to share, because it all starts with acknowledgement in my mind. And Laura, you really built a great storyline for me. So thank you. Talking about equality and equity, right? Because most times we confuse that. So I'm going to add one more thing, and that connects with the acknowledgement is inclusivity. So something that most times when we discuss about social determinants of health or health equity, it becomes more racial, ethnic, cultural. But one thing is ability. So we don't very often talk about ability, and that means or lack of thereof, which is disability. Even in COVID or communications, including them is equally important, even in Medicare population, more than ever than others. Certainly even Medicaid, I would say, because the government programs include most of them. So that acknowledgement is important. And being a quality passionist, I would say, as much as health equity is health quality, and Institute of Healthcare Improvement has acknowledged it, HRQ has acknowledged it, but we also have to include that inclusivity portion. And that leads to next portion, which is any journey mapping we do, and in Medicare, this is much more common, and Lora built that with the communications, and many organizations do that, healthcare certainly, even providers, is including a member's perspective, and that means even members who lack the ability is equally important in journey mapping. And very rarely do we see that portion in journey mapping. And how do we start that is with the acknowledgement. So I came full circle with where I started. And what does acknowledgement mean? And colleagues like Dr. Creshelle, Dr. Nash, I would say, RJ, Lora mentioned about it, right? We need to look somebody like us to get rid of that hesitancy, to connect, to trust. And that includes even the communications. How many times have you seen in communications, including this cohort of people, right? Very few times do we see that. Most communications, may it be breast cancer screening, may it be COVID vaccination, may it be flu, we don't see that. And at Johns Hopkins, that was something that I really did in 2019. And it was partly because it was a personal experience, instance that happened with my mother, because that's when we really, really connect with something. When she fell and she's now unable to walk or walk very short distances with support, is when I realized what others might be going through. And to that end, I started looking into this and adding that perspective in social determinants of health, in cultural competency that we talk about in healthcare. And the acknowledgement came with a simple thing. We send these welcome calendars to Medicare members. Most plans do this. This is not something groundbreaking idea. But for 2021 at Johns Hopkins, we made a conscientious effort of celebrating diversity and vibrancy, and which means not only cultural heritage months and topics that are important for those groups, and that included even disability. And when I said the timing is right for your podcast here, is October is actually Disability Employment Awareness Month. And so what a timing in a month and a half now, or in 6 weeks, where we would celebrate it. And to that end, one more thing I do want to also bring up is for National Disability Awareness Month goal for 2021, they have America's Recovery. And I specifically wrote it, powered by inclusion. So that tells you something, that we really need to include these people. It went further, not only just with the calendar, but any mailer we sent thereafter really included not the diversity aspect, but also that inclusion aspect. I'll give you a great example. It was a diabetes mailer to encourage physical activity. Well, not most times you see mailers of any age, including seniors, doing some kind of rigorous physical activity, running, walking. Again, you're not including. How about having simple exercises where you can sit on a ball and make yourself active? I mean, it's just something, and Dr. Nash, please feel free to chime in as a clinician here, but something I feel very passionate about. And that goes now, finally, having those meaningful connections with what Lora brought up. I would 100% attest, especially if you have demographics in metropolitan areas and even in rural areas. So it's not limited to metropolitan areas, omnichannel meaningful communications. I saw a tremendous response in texting. Lora, you talk about texting for reminders. It's not only just reminders about screenings, but medication adherence reminders, prescription refills reminders that I think CVS does. I do get reminders from CVS, is also something important. And the response you get is meaningful in a way that not only we have had people responding, can you make communications in different languages? Can you remove me from this communication? I would rather get mailers, or actual live phone calls. So that kind of helps us build the segmentation of what the preferences are and how you engage people, connecting that equity with engagement.
That certainly, that all makes perfect sense. And I know it's harder to execute than to just simply say it. Are you able to measure any improvements or declines based upon communications in exclusivity? I mean, are you able to see that? You mentioned that diabetes example of the exercises and the ball. Are you able to see we excluded people by not doing this, and now that we're doing this and recommending that, we're improving our inclusivity number? How is that being measured?
So that work is in progress, but one of the things, if you including people, just not disability or lack of ability, is one great example Lora brought up, flu vaccination. The numbers and the numbers for Medicare beneficiaries, which is measured by a quality rating program called Star Rating Program, which is due in October again. I can assure you, texting, we ran a whole campaign about flu vaccination, and this was pre-COVID, early on, because of the timing of the surveys for member experience. Let's put instead of sharing the results, let's watch the results, and the results in October will tell you, including communications and different modality and different populations, and having a perspective what the results are. Like I said, given the compliance requirements, can't share, but in a few weeks you'll see the results. So stay tuned.
I'm gonna shift it back. Thanks for that. Tejaswita. RJ, can you provide us an example of how you guys are closing the gaps in care and how maybe you're measuring the results of such a program?
Yeah. And Eric, you gave away that we might have spoken about this sooner, because we have an amazing program called Close the Care Gaps in our Medicare Advantage program. And I'll take exactly zero credit for this, except for being a cheerleader for it and actually working with this team to just continuously improve this. This is, I'm going to try to hit one of the questions that I saw in the Q&A a second ago on this, but it's going to be a difficult pivot because this is actually for Medicare. And the question is specific to Medicaid. And that person asked, like, how do you get the funding to do SDoH in a Medicaid program? Because you have to do it. And that whoever that person is, it said anonymous attendee, but anonymous attendee may be me in another world, because that is the toughest thing, right? Like everybody who is who's authorizing budgets in our world needs an ROI on it quickly, and these things do not have quick ROI. So here's my little pivot to Medicare Advantage. Again, we get a little bit more time with those members because the members, we can kind of count on having these members longer than we can in a Medicaid. That's just an unfortunate reality, right? But you've got to, so I'll answer that question this way. You've got to be able to find a way to set aside, and this is the hardest thing to do, set aside some funds to be able to do that for, call it an innovation budget, call it, whatever you want to call it, that's not on the plan's P&L, and then have a definite timeline where you want to shift that to show the ROI. It's really, really hard. I'm happy to talk and consult with folks more about that offline. But so this is our Close the Care Gaps program in Medicare Advantage, really focusing in on culturally delivered care. Very specific group of folks. This is still, call it pilot, although it's fairly large, 3 states, fairly large set of members that we're looking at. So this is for Black and Hispanic members with diabetes and/or hypertension. And one of the things that they did was, the first thing they did that's super impressive as I learned about this program is just a ton of research, really qualitative, in-depth interviews with our care managers, our providers, our providers that are in network with us, and the beneficiaries, and then some quantitative data on the Black and Hispanic population in Medicare Advantage. So what we found with this population enrolled is 87% of those members have 4 or more chronic conditions. And so a really fantastic approach to this, with C's being the key words here. So culture, the members' culture impacts how they receive healthcare and how they approach it, but it's not everything, right? It's not the only thing. And then again, we're going back to our favorite word, trust, right? Connect to establish trust. I'll say one of the findings, we're early in this program, but one of the findings so far at the point we're in now is it takes a lot of time to establish that trust, right? And so that's a key learning, and that's something that we have to communicate well up as we want programs like this to succeed. The next C is coach, to be encouraging small changes to address these acute issues, right? If you make a lot of small changes, there's a lot of great science behind that. And then the C is consider challenges related to SDoH, but don't assume those, right? Like, so if you just look at the data, we're doing a fantastic job at getting data on social determinants of our members and kind of getting that down to the individual level, but you still can't assume that member has all of those social determinants issues that the data may say they have. So just real quick, key interventions on that is using care managers who are of the backgrounds reflecting those populations. Huge. There's a lot of cultural competency training, which goes above and beyond the standard click through it and get done as quickly as you possibly can. Really engaging training. as the care managers and others who come in contact with the members have motivational interviewing techniques that are multicultural based. One of the big needs that showed up was, and the point of this program, the way it comes back to social determinants, is to be able to refer members to community resources, community-based organizations. Peer counseling has come up as one of the things that members want to see. So we're in the kind of phase where, what are we seeing from these members? What do they want? The distribution of integrated cookbooks has been a really big one, and one of the bigger needs we've seen is enhanced referrals to dietitians and nutritional support. So we're in the phase where we're seeing like, what do the members need to be successful in this, and deploying more of those resources right now.
Okay. What about at Johns Hopkins, Tejaswita? How are you closing those gaps and measuring them? Anything different?
So not different, but I'll address the question of it has a different twist, and address the question of ROI, right? What RJ started, and there's a question in Q&A. And that's one of the biggest barriers actually with social determinants of health initiatives is the ROI, because at the end of the day, we all have to answer to our finance folks, and the time commitment needed. It's not something in 6 months or a year. It is multi-year project. I mean, general ROIs are 3-year or 5-year. That's what I'm used to. It is much longer than that, and the complexity associated. With care gap closure, one of the things that I'm proud with this inclusion and health equity was many health plans shifted their strategy of care gap closure, talk about diabetes or even blood pressure, common culprits in any population, was mailing at-home testing kits. In past, health plans have done this, but in a limited space. And at Johns Hopkins, when we launched it, it started with Medicare, of course, because these innovations, purpose-driven innovations, can really go well with Medicare population given the financial support and the focus they have. But number one thing, we also included Medicaid in there. And the results with Medicare, with ROI, and this is pure program evaluation, certainly surpassed years before performance of closing gaps. So there is a financial motive, which was kind of expected in Medicare, not surprising. But what was surprising was in Medicaid, where we were able to receive the results for diabetics that hadn't been tested for the last 2 years. At least we didn't have a record of their A1C value for the last 2 years. That's a huge gap that any clinician or anybody here on this panel can recommend, which was really eye-opening. And the response rate was in double digits. For Medicaid, getting that level of response rate, of return response rate, is highly unusual, and especially when you have launched an initiative like that in Q4. So that was really a key driver, and has helped propel additional programs like remote patient monitoring. Now, with remote patient monitoring, there are additional challenges as well, right? I mean, smartphones, not everybody has smartphones. Even though we talk about an omni-channel preference of communication, but smartphones are not something that you'll have it. And especially with Medicaid population, where we really want to implement some of these programs, because Medicare has been trying these for a while. So it kind of gave us that edge of starting small, of course, in a member journey, but even providing members with smartphones and necessary training. And this is where I come back to closing the loop. What RJ brought up is care management support. You need that live agent support rather than IVRs or just instructions and availability of it, to drive that remote patient monitoring and engaging them. And that's the first step towards it. So how you execute and how you go about explaining the value proposition of small things you do, even as pilot, is what is critical. And that was something, did I know going in? No, I didn't. It was a learning process, and it still will be. So if that kind of helps you get the approach.
This has all been, everyone's providing such a wealth of information. I know we can't sort of dive into each single one of these with the limited amount of time we have, but thank you. That's great. I do want to give Icario one more quick shout out because without support from organizations like them, we can't do this show. If those of you joining us late, they are a company that is intelligently reaching your members that need healthcare interventions the most, while at the same time driving low and moderate acuity members to action with personalized outreach at a large scale. So combining sort of technology, modeling, know-how, and the human voice. And this is sort of what I meant when I said at the beginning of the show, pragmatic and non-healthcare, because they take a very Madison Avenue approach to understanding different consumers' values. So they deliver specific words and distribute those words in a way that inspires a behavioral change. So if you think about the biggest brands in your life, although their words and advertising are different than maybe your employers, the principles are the same. You want to move the needle with your population health and value-based care, and you start that, you need to think differently about how you engage than certainly what you're doing today, because clearly we're not as good in healthcare as marketing to consumers as some of those big brands that we all know. So just wanted to give them another shout out. Also, a really cool opportunity for all of you who are listening in. They have this very highly rated innovation series coming up in 2020. They're called Rev Up 2021, excuse me. And I could tell you, as someone who attended their live event a few weeks ago, they put on a great show and get great presenters. So this is a virtual series. There's going to be 3 60-minute webinars in September. This is September, where they're going to have top industry leaders from CVS, Aetna, United Health Group, Nightingale Partners, and a lot more. And they're going to come together to discuss healthcare's hottest topics, from innovation to member experience to SDoH. And it's kicking off on September 14th at 1 p.m. Central Time with a keynote from Anish Chopra, the first CTO of the US and the current president at a company called Care Journey. So if you want to go to that, or at least get information on that, we will register for you. Just click on the poll yes, and we'll get you all that information, and you get to get out, and you could be registered and go to those 3 sessions. A lot of great content. And I'm telling you, I went to their event. It was unbelievable when I went to their live event. All right, I'm gonna stay on the topic of sort of consumer brands and other industries and how they're doing a better job at learning and implementing. And so, Lora, could you talk about how healthcare plans can take a page from Starbucks? I'm drinking some Starbucks right now. They're not sponsoring the show. They should be. And Starbucks' approach to data, social determinants of consumer engagement, and how we could apply that here in healthcare.
First off, I really hope my boss is on the phone, because when you called what we do Madison Avenue levels of communication, that's my team, and I just want someone to have heard it. Yeah, absolutely. All of you guys know that Starbucks, I mean, there's several brands out there, but Starbucks is a great example, is one of the best organizations that's figured out how to communicate with us, right? How to communicate with us individually in an N of 1. If RJ and I both have the Starbucks apps and we both like the same drinks, but he likes his with a whole pile of whipped cream and gross sprinkle things. And sorry, I'm sure they're lovely for some people. And then I drink
That's
mine.
not me, by the way.
Yeah,
Just,
I know.
just so everybody's clear. Yeah. Good example.
Like a real cup of coffee. No.
Shots of espresso, and that's it for me.
See, exactly.
Yeah, not even coffee. Yep.
If you go to your Starbucks app, the picture that shows up of your drink is your drink, you guys. It doesn't even.
It is.
Weird whipped cream and sprinkles thing, which good for those people who drink it. Anyway, it's a level of N of 1 that means that Dr. Nash and I are both going to have a great experience with Starbucks that is built entirely off of a combination of data and analytics, primary research, secondary research, and modeling. And it's brilliant. We in healthcare, of course, would love to get there. We're not exactly there yet. Most of us don't have apps. There's a question in the chat that's like, how do you even get these people to let me test them? Which is true. But we can do elements of that in how we communicate, and then with the idea that eventually we'd go there. I'm going to actually use an example that's kind of on the opposite end of the spectrum, but we were doing, as we all know, healthcare activities have been lowered in the past year for pretty much all populations, but certainly for our Medicaid populations, not just vaccines, but office visits, flu shots, whatever. So of course, because it's me, we decided to do some research to try to get to the understanding of, we knew that there's going to be impacts of what's been happening in the world. We knew that there were going to be factors, of course, all sorts of SDoH factors that are going to impact how people are able to engage. And so we did some secondary research. Of course, we looked at our data and we looked at who was engaging and what they were engaging and what they weren't. And then we went out and started doing some, not in person because we don't want to kill anybody, but over the phone and survey research to say, hey, what are the SDoH factors that are impacting you? And of course, it's everything, you guys, right? I mean, it's transportation, it's food, it's whatever. But we discovered with our Medicaid population with kids, and this is across the country, the number one factor that they mentioned was technology across the board. Technology was number one. Now, that doesn't mean that they're not also looking at housing insecurity and food and transportation, obviously. And we thought, well, okay, I mean, maybe it's just because of school. Like, I mean, that was our first consideration. But when we started doing the interviews and started digging into it, no, it's because it's everything. I mean, it's we can offer all sorts of transportation, but where do they sign up? We can offer all sorts of telehealth so that they can get visits. But if they only have a cell phone, for half of them, that wasn't even accessible. We can offer food delivery, but where are they going to call? I mean, it was everything. So as a result, we're starting to research how one can look at the great digital divide to create equity and equality so that we can have people have access across the board, but then also the kind of access that they need. And so we're even looking at partnering with some of our clients around offering things like partnership for something like human IT so that they can have as an engagement as part of their healthcare, somebody to help them set up technology in their homes, because it isn't just that they don't have it, it's the barrier of understanding of how to get it, which is a massive, massive consideration and concern. So we're working with partners to say, what if we set this up and you paid for it? You want to talk about ROI? You paid for it, and then you can show that if you're paying $10 a month for somebody to have broadband, they're this much more likely to get their physical, which is I mean, obviously we have impacts across the whole board. So yeah, it's not Starbucks. I mean, we're not doing coffee in that particular range, but we are figuring out for an individual how to communicate and how to engage them in a manner that's going to be impactful for them and make the RI. Not yet, but yeah, we'll show it.
I can't stress enough, guys, if you want to just pick the folks at Icario's brain, they just look at it differently. By now, you've probably received another email from me with the survey. We ask for your feedback on today's show, but also what other topics you want to cover. You could request to be introduced to the Icario team, and I'll personally introduce you. So I will send an email and CC you and introduce you. So if you guys want to get to know these folks, if you don't already, and just pick their brain, not even necessarily hire them right away, just to see this insight, I'm happy to do it. I think it's a great value to everyone. We've got 8 minutes left. Here's what we're going to do. I want to talk about what everyone on the call can do tomorrow. We're going to bring in Dr. Nash to do that. And then we're going to close out with RJ, who's got a really cool Look Like Me pilot he wants to tell everyone about so you can hear about it. So that's what we're going to do in the last 8 minutes, because I know we're jam-packed here. So for those who want to take a small step forward in any of these approaches, or a type of approach to build trust, let's say in the next week, how can individuals today, Creshelle, enhance their organization's approach to better building trust with the underserved populations next week? How would you advise them? Give us an example.
You know, that is a wonderful and a $64 million question. I will say that trust is a journey. And what I have known from my experience is that it's really hard to build. As we have said, it takes time, but it's really easy to break. When I think about what we're doing right now, and you ask me what would I tell an organization to do tomorrow, I think first, when you're approaching underserved communities, you have to realize that those people who live in the community and who lead the community are expert in their community. And we need to tap into that expertise. And it is not a deficit model. These underserved communities are also resilient. So we have to come from that mind frame instead of what's wrong with you, what's wrong with this community. I think what we are doing as an organization is having community conversations around all of this, two-way conversations. And right now it's in the context of COVID, of course, because my whole life is COVID, but it goes way beyond that. We are building relationships for the future. And I will say that when you have those conversations, don't come from a deficit model. And it cannot be a conversation that stops at a conversation. There has to be true partnership, power sharing in it that gives resources and control to local communities and local leaders. They know what their problems are. They know what the solutions are. So the first step, I believe, is those true conversations that lead to those action steps. Otherwise, you just have conversation for conversation.
Well said. Well said.
Well said. Yeah.
RJ, close us out. Look Like Me pilot. Tell us about it in the few minutes we have left.
I hate that I have to follow that. That should have been the closer. Well said. Here to all that, and hopefully you heard that's what we're trying to do in our work. Okay. Yes, I want to jump on this, and then also major +1 to Lora. If you don't take anything away from this, take away. I have homework to do now too. That digital divide is the #1 issue for Medicaid members. That's something very unique and something everybody that's interested in this needs to focus on. Here's a tiny little step into it. Again, trust. So quick hypothesis from our fantastic pharmacy innovation team with a hypothesis that enabling patient choice in provider selection can build trust and then maximize the quality of the consultation that they get, right, and the impact. So member, or not member, I still say member, I'm Aetna, I'm CVS now, but it's hard to get out of member being in a health plan my whole life. So the patient leaves the store and they get a text, right? So it's quick when you're at the counter. The pharmacist doesn't have a ton of time. We know that. We've got a lot of things at work trying to solve for that, right? So the customer gets a text to schedule a consult if they want to. This is mainly for folks with something new. It's a new therapy or it's a newly discovered issue that they have, again, in demographic areas where we believe it's underserved, right? So they get this invitation. What that solves is patients leaving the pharmacy with unanswered questions. They need some space or privacy on their own to kind of figure out concerns or doubts or something like that. Here's the cool thing. We didn't do decks or anything, but they get a menu of pharmacists with their photos and bios. So again, to the earlier conversation, Black or Latino, women, men, pharmacists, right? They actually pick the actual pharmacist that they want to have that conversation with, right? So obviously, if you're any patient, especially racially diverse patients, would really rather get their information from a relatable provider. And then so that enables them to get a 10-minute kind of open-ended consult. So that it will give them that personalized information for where they are on this journey. So this was a quick pilot. We're obviously very interested in expanding it, but it did return a easy for me to say, statistically significant improvement in the medication adherence and persistence to the next refill for that test group. So more of that on the way. I've got a whole block of work on providers that look like me that we need to do better on, both in CVS and Aetna.
Awesome stuff. If you want to reach out to any of these panelists, they're all on LinkedIn. I want to also remind everyone, Sherry, thank you for doing that for me because I would have forgotten. Thursday, September 23rd at 12 p.m. East Coast time is our next live event on why patient engagement is not working. It's going to be a really interesting panel. So join us for that. We're going to have a couple of interesting shows drop in the podcast feed as well, including the CEO of Metro Plus Health Plan in New York City, who I just interviewed. Really fascinating conversation about what they're doing in New York City with 23 different languages in their member population and how they deal with that. So subscribe to the podcast to get hold of that. Thank you, all four of you. Creshelle, RJ, Lora, Tejaswita, just really great stuff. Appreciate it. I know it was really hard to stay on time today. I know we didn't get to everyone's questions. I apologize. We just had a ton of content. A lot of people on the call today asking a lot of great questions. I just couldn't get to it all, but thank you all. Please take that survey. You could criticize us for not getting to, criticize me for not getting to your questions in the survey. So take it out on me, but please do give us that feedback. We take it very, very seriously, as our regulars do know. Really appreciate it. This will mark the end of the show. Shout out to Sherry Keels, our senior producer, who put together this great panel. That's why you get all this great content. I have the easy job of just showing up here. So thank you all. Have a great rest of your day, and see you on the next live Bright Spots in Healthcare live recording and podcasts. Take care, everyone.